Hi, good morning, everybody. It's a real pleasure to welcome you to today's Grand Rounds. We have a very special speaker. I'm thrilled to introduce Alina Allen, who's visiting us from Mayo Clinic. Alina is someone whose career I've followed with great pride and admiration for the last several years. So Alina grew up in Romania, attended medical school in Iași, which is on the border of Moldova, a beautiful medieval city. Came to St. Louis for residency and chief residency, and then moved to Mayo Clinic, Rochester for her GI fellowship, advanced liver transplant fellowship, and stayed on faculty there, where she's currently an associate professor of medicine. So Alina has many honors and accomplishments. She's been recognized by the AGA, by the AASLD, and the European Association for the Study of Liver Disease, where she led a master class in steatotic liver disease. She has over 75 original scientific publications that have focused progressively on defining and validating the use of imaging technology, particularly MRE, in steatotic liver disease, as well as stratifying risk for transplant recipients and outcomes. And Alina was very involved in the new nomenclature for steatotic liver disease, which is what she's going to talk about today. So in addition to her scientific accomplishments, she is a wonderful role model for women physician scientists and clinicians. She's highly regarded as a leader in the clinical liver services at Mayo. She's mentored many residents and fellows, and she really is a tremendous and visible role model. So it's a real pleasure to welcome her. Please join me in welcoming Alina Allen when she talks about fatty liver disease and its new nomenclature.
Thank you so much for coming and taking the time to be here so early in the morning. The focus of today's talk is not only the nomenclature, but anchoring the nomenclature change on what we need to know about diagnosis and treatment currently in steatotic liver disease. These are my disclosures. So today's learning objectives are to describe the new nomenclature and definition of the disease previously known as non-alcoholic fatty liver disease, to recognize patients who are at risk for metabolic dysfunction-associated steatotic liver disease, or MASLD, which is the new name, to employ risk stratification algorithms to determine the need for hepatology referral, and to use updated strategies for the treatment and care of patients with MASLD. So essentially what I'll try to do is a little whirlwind of what do we need to know when we meet a patient who may be at risk for MASLD in clinic. When do we send them? What do we do if we don't send them to hepatology? So NAFLD is now MASLD. There has been an update in name from NAFLD, which included a term that was considered not speaking to the pathophysiology of the disease, was an exclusion of not alcohol, and also a stigmatizing term of fatty, which some patients or some physicians found stigmatizing. So this was turned into metabolic dysfunction-associated steatotic liver disease, essentially to recognize that at the core of this disease, there's a metabolic dysfunction as a cause. There was also an update in definition. Previously, it was defined as steatosis in the absence of other etiologies, such as more than moderate alcohol use or viral hepatitis. Currently, we need the presence of at least one metabolic comorbidity to make this definition. So I'll speak about this a bit more, but essentially, MASLD is now a subtype under the umbrella of steatotic liver disease. The aggressive form of MASLD, which is now called MASH, the steatohepatitis, which is a higher risk of progression to fibrosis, is under this subtype. But there's a newcomer, a new kid on the block called MET-ALD, which is that phenotype that combines metabolic dysfunction with some alcohol use, and we will talk about that in the next slide, Alcohol-related liver disease is also a subtype of steatotic liver disease, as are other specific etiologies that are listed here. Cryptogenic SLD means there is steatosis in the liver and none of these criteria are met. This schematic summarizes what do we do to approach the patients with steatotic liver disease. So a patient who may have either incidental imaging findings of steatosis or a biopsy, the next step is to ask, does this patient have more than one metabolic criterion? And these are the 5 criteria of metabolic syndrome, which we all know. The difference between that and MASLD is that we only need one. So either overweight or obesity, abnormal glucose, abnormal triglycerides, or high blood pressure. If they do have metabolic criterion and they do not have any other causes of steatosis, then we call them MASLD. If they do use alcohol, then they may be met-ALD. And the numbers that are to remember are 2 to 3 standard drinks a day for women and 3 to 4 standard drinks a day per men. This is the met-ALD category. If there's any more than this in terms of alcohol cutoff, then they are called alcohol-related liver disease. I put this illustration here as a reminder what a standard drink is. When we ask patients, do you use any alcohol, we need to really clarify that the amount of wine that they use is really 5 ounces and not a full glass, as people may pour more at home and so on. So having this graphic in mind would be useful. This is going to come in gastroenterology later this month. So this disease is really the most predominant chronic liver disease nowadays. In this graph, you can see how the prevalence compares to the others, alcohol-related or viral hepatitis. And this was in 1998 to 88 to 94, where it was 20%, but then it increased significantly over the latter years to up to 38% on the most recent meta-analysis. Why is this important? It is important because people with MASLD are more likely to die than people without, irrespective of fibrosis stage, irrespective of their comorbidities. Fibrosis stage does matter. The higher the stage, the more likely their mortality risk. And it's also important because it is the #1 cause of liver transplantation in women nowadays. As you can see here in red, it has really spiked over time to now the top. It is projected to become the top for men and women in the next few years. Currently, alcohol-related liver disease remains the top cause for men. It is also important to recognize that this disease has a very slow clinical course until cirrhosis onset. This is a study that we performed in the population of Olmsted County, which is the county around Rochester, but it's not just served by Mayo Clinic, it's the entire population in that area. And we followed them over 25 years. And we determined that before cirrhosis, people spend about 15 years in this stage. So it's a long time. About 3% progress to cirrhosis, but once compensated cirrhosis sets in, their time is accelerated. 4 years until first decompensation and then 2 years until subsequent ones. So how do I identify these patients? The idea is to find them in that blue box, in that the 15-year time before they get to cirrhosis, where the disease is still reversible. So we'll talk a bit about how to approach this. Based on the AASLD guidelines, the people we need to think about having risk for MASLD in the primary care setting are these. So people obviously have abnormal transaminases or have metabolic risk factors, at least one, as we mentioned before. They use alcohol in more than mild amounts. They have a family history of cirrhosis. This is important because it doesn't quite come naturally, but it's important to ask. Or they have found to have incidental hepatic steatosis on imaging performed for other reasons. If we were to remember one thing from this talk, maybe it's this. People with type 2 diabetes have the highest risk. From this recent meta-analysis, we know that 2 out of 3 patients with diabetes have MASLD. Overall. Of these, about a third have MASH, the aggressive form that includes steatohepatitis with risk of progression to fibrosis. and almost 1 in 5 have advanced fibrosis. This is defined as stage 3 to 4 fibrosis, either by biopsy or by fibroscan. So when you see a patient in clinic with diabetes, asking, is this patient at risk for fatty liver disease or for MASLD, should be part of the same question of does this patient have risk of eye disease, neuropathy, or nephropathy. There are barriers to early diagnosis. The first one is simply the sheer volume, knowing that 1 in 3 adults in the US have MASLD. People don't have symptoms until end-stage liver disease, although some do have some right upper quadrant discomfort. This is one of the main causes that they do get an ultrasound or some imaging. Important to note that the liver enzymes are normal in most patients with MASLD and in about half of the patients who have MASH. So it is hard. We need to really intentionally think about who is at risk because we cannot rely on these signs that are typically considered a sign of liver disease because they're not always there. And early diagnosis allows timely intervention to prevent disease progression towards cirrhosis and liver cancer. Also important to note is that patients may have other symptoms that are associated with MASLD, but not specifically liver-related. And these include some of these that are summarized here. They have anxiety, depression, sleep symptoms, abdominal symptoms, as I mentioned, general abdominal pain. They may have fatigue, poor quality of life. So these are important from the patient's perspective to screen and consider, could this be a sign of early disease so we can diagnose this before the late stage symptoms occur. Another reason why it is important to identify this disease early is because it is a risk factor for incidental comorbidities later in life, such as diabetes, hypertension, and dyslipidemia. This is a study, again, from the natural progression of this disease in a population, not in a center, where we looked at the risk of developing diabetes, hypertension, or dyslipidemia after being diagnosed with MASLD. And this risk is more than double. So if we want to prevent diabetes and the other comorbidities, it is also another reason to intervene early when we know that this disease exists. So the overall schematic of understanding this approach to this disease is, one, identifying the high-risk groups that are likely to develop MASLD. And again, prediabetes or diabetes is at the top. This is based on the endocrinology guidelines. Patients with obesity or cardiometabolic risk factors, ruling out other causes of disease as we showed in previous schematics, and the goals are twofold. The first goal is to prevent cardiovascular disease because that is the most common cause of death in this population. It is not liver disease. The reason is, as we said, the risk of developing all the other cardiometabolic risk factors. And then the second goal is to prevent cirrhosis. So what we'll focus next is how do we prevent cirrhosis? How do we risk stratify for fibrosis? Histologically, the progression of this disease starts with simple steatosis, then MASH, which means ballooning of the liver cells and inflammation, and then fibrosis, which is measured in 4 stages, 1 through 4, with 4 being cirrhosis. Currently, in clinical practice and in clinical trials, we focus on this category of patients because we need to start somewhere, and we start with those who are at highest risk of death and comorbidities. And out of these, all of these histologic factors, fibrosis is the most important. Why is that? Because this is the one determinant of mortality. And as you can see here, the mortality rate increases based on fibrosis stage, and this increase starts around stage 2, and it is exponential afterwards. So the current guidelines and the current clinical trials focus on stage 2 or higher identification. The methods of fibrosis estimation are either serum biomarkers or imaging, which essentially means elastography. And these are to be used sequentially or at the same time. And the type of biomarker really depends on the availability in everybody's practice. This table summarizes the most studied serum biomarkers. The ones listed here at the top are the ones that include routinely available parameters, such as the ones listed here. The ones in gray are proprietary tests, which need to be ordered as such because they include other parameters that we don't really check on a daily basis. The performance is listed here, and from the ones that are most commonly studied, FIB4 is the one that's used mostly because of ease of calculation, but also because of the performance. This test was developed for identification of advanced fibrosis, so it doesn't quite catch that stage 2, but again, it's a good test for the extremes of the disease severity. And the second one that you will see listed in the guidelines, as we'll talk later, is ELF score, which is a proprietary test, and you can see its performance here. Caveat about these scores, and I'll use FIB4 as an example, but this also applies to ELF. We need 2 cutoffs to remember, and up to half of the patients will be in this gray zone between these cutoffs. For FIB4, the lowest cutoff to remember is 1.3. Anyone with less than 1.3 FIB4 score has a high negative predictive value for exclusion of advanced fibrosis, so it is a good rule-out test. The higher cutoff is 2.67. It's not as good at this extreme because the positive predictive value is lower, so we will essentially overcall a third of these patients as having advanced fibrosis when they actually don't. So it's not good for rule-in advanced fibrosis, but it's a good cutoff to know that, oh, this patient is at risk, we need to do something else. About half of the patients will live in this gray zone, so what do we do here? A sequential non-invasive test, which will decrease this indeterminate zone to approximately 20% from the other studies. The FIB4 calculator is very easily found online. This is just a snapshot of MD-Calc. It includes age, AST, ALT, and platelets. So again, this kind of assumes that we do check these tests in these people at risk. So making sure that we remember that these need to be ordered. It's one of the sine qua non of having this test, actually. It gives the score, it gives the interpretation, and then if you click further, it kind of gives further recommendations. It can also include it as a dot phrase in EPIC for ease of calculation, and can also be automated. ELF has also 2 cutoffs. The lowest one is 7.7. It has a pretty good sensitivity of 85% of exclusion of advanced fibrosis. The higher cutoff is 9.8, which has a specificity of 90% of determining that the patient is at risk for advanced fibrosis. So we wrongly diagnose about 10% of these patients. The problem with this score, just like with FIB4, is that a lot of patients will have this gray zone. From a recent study, up to 80% from the general population can be in here. So again, kind of identifying this risk in patients who have metabolic comorbidities narrows down this gray zone a bit. Elastography is the other method of fibrosis estimation, and what this means is shear waves that are applied to the liver that essentially displace the liver tissue. The wave velocity is measured, and this relates to the liver stiffness. The stiffer the tissue, the faster the waves travel. There are 2 technologies for measuring this elasticity. One is ultrasound-based, and the other one is magnetic resonance elastography, or MRE. Ultrasound-based technologies come in different flavors. The most common one is vibration-controlled transient elastography, or VCTE, or FibroScan. There's also shear wave elastography, which is acoustic radiation force applied in either one location or multiple location, and this latter technology is integrated in the conventional ultrasound system. So it has the advantage of providing not only the liver stiffness measurement, but also more information about the liver and the spleen, etc. I want to spend a few seconds to mention that the MRE is the short, non-IV contrast 10-minute exam that essentially focus on measurement of steatosis and elastography. We do not need a full MRI with IV contrast, which adds to the time about 4-fold and also to the cost. This shows you the contrast between these technologies in terms of how far and how wide these waves, the shear waves, travel. MRE has the advantage of imaging a higher volume of liver. It's essentially 4 slices that are cross-sectional. A bit about FibroScan. Waves travel through a cylinder space of 4 centimeter length and 1 centimeter width. It penetrates about 65 millimeters below the skin surface. And this volume is 100-fold bigger than a biopsy sample. So essentially much improved over that 50th thousandth of the liver we look when we look under the microscope. The limitations relate to this distance. Central adiposity, so the depth of subcutaneous tissue, can affect its performance. So it can lead to failure to measure or lead to unreliable reads. Its major advantage is that it's a point-of-care test. It can be taken to the clinic, either in hepatology clinic or even endocrinology or primary care, and it's at bedside. We get 2 numbers from FibroScan. The blue one is CAP, which is continuous attenuation parameter. This is a measure of steatosis. And you can see the performance of steatosis measurement from any grade of steatosis, and the performance goes a little bit lower when we try to be a bit more granular. Is it grade 2 or grade 3? The second number we get is liver stiffness measurement, which is the measurement of estimation of fibrosis. The performance is pretty good for cirrhosis, 0.89, but it goes again a little bit lower when we try to identify more between these degrees of fibrosis. So, for example, in clinical trials, when we try to identify does this patient have stage 2 or stage 3, it's a little bit harder to use. MRE uses this probe to apply over the liver and send these shear waves that are afterwards transformed by the software in an elastogram. The redder areas, the stiffer the tissue. The acquisition time is approximately 1 minute. The volume of liver assessed is 2,500 times bigger than the liver biopsy. This recent meta-analysis from a large cohort of almost 800 patients from across the globe shows the area under the curves, or the performance of identification of each stages of fibrosis. And as you can see, it's above 0.9 for even the lower stages, F2, F3, and F4. So it is very good to provide more confidence when we recommend to the patients. I'm pretty sure you have stage 1. We don't really need to think into the algorithm of management, or 2 or 3. Patients love numbers and they like to trust numbers. Importantly, it is not confounded by liver steatosis, which FibroScan can be, and it is not confounded by body mass index. The disadvantage is the fact that it has to be scheduled in an MR suite, and it is also more costly than the FibroScan, but again, not as costly as a full MRI. The discordance between MRE and FibroScan increases with BMI, and this is an important point for situations where both technologies are available, which I think is the case here at WashU. And in this very important study, they looked at the discordance based on the BMI ranges, and as you can see, it starts increasing from 30 to 35, where MRE is closer to the truth. So use this cutoff of a BMI of 30 to 35 when you have to make the decision between the tests that you could use. What we use at Mayo Clinic is this rapid MRE, which is, again, 10-minute exam looking really just at the phases that are important for this disease. We get the fat fraction, which is the most accurate way to non-invasively estimate the degree of steatosis, the iron content, which may be important in diseases such as iron overload, and this liver stiffness, which is accorded to fibrosis and inflammation. The CMS charge for this short version of MRE, which has its own CPT code, is $289. So how do we risk stratify, and how do we put these tools together that we learned about to determine who needs to be referred to hepatology and who can be managed in the primary care or endocrinology space? And I'll start by the fact that we need to work together to identify this disease. It is not only needed for identification of the disease and the risk stratification, but also for management, because in hepatology, we can't really address all the issues such as diabetes control, weight management, and things we'll talk about later. So we really need to apply a multidisciplinary model of care for this disease to make an impact. Primary care has a central role for screening, for referring, for promoting weight loss and lifestyle changes, for optimizing control of metabolic syndrome and cardiovascular risk assessment and prevention. So we need to collaborate between us and secondary care with both hepatology and endocrinology. We need to work as a field to develop effective systems that enable this partnership between disciplines for screening, referral, and management. It's not as easy as it sounds on a slide or on a paper. There are challenges in these pathways. The centralized approach relying on primary care physicians is not easy because there are time constraints. Everybody's busy. There are a lot of comorbidities nowadays. Harder to remember that we need to consider liver in that piece of the puzzle as well. There's lack of uniform guidance and care pathways that are tailored to local resources. We have guidelines, but they don't always apply to each institution or clinic. There's also suboptimal knowledge and training in this disease, unfortunately. There are unavailable structured disease management programs. What do we do with these patients? Who do we send them? Who is going to manage their weight? Who is going to monitor that? How do we do that? So these barriers have been really nicely described in a recent global survey of physicians' knowledge published last year. And you can see the biggest barriers that are in primary care and in endocrinology, and these include lack of confidence in managing it, time constraints, failure of patients to adhere to lifestyle medications. There's this sense that, well, I can say what they need, but they won't do it anyway, so why bother, which is unfortunate, but we need to push through that. And there's also lack of availability of effective drugs. It's not uncommon that we get the question, okay, so if I diagnose it, how do I treat it? There's no treatment for it, unlike hepatitis C or B. In another survey, actually, this was actually a United States one. The question was posed, what would you do in a patient who you know has high-risk MASH, is a diabetic, has an indeterminate FIB4? What do you do next? And unfortunately, a lot of them answered ultrasound. And as you can notice, I have not really mentioned the role of ultrasound in risk stratification because we don't really get any estimation of fibrosis from that. We get presence of steatosis, but that can be also obtained from a fibroscan or an MR elastography. Some use serologic markers for MASH. There are not that many and not that accurate. And unfortunately, elastography, which is the one that's included in guidelines and we just mentioned, was very rarely used in primary care practice. And also referral to hepatology occurred in less than 20% of those patients who are at risk of having fibrosis. As you recall, at least 1 in 5 people with diabetes can have this disease. So we need to do better. We need to work together. We maybe need to educate more and maybe make it more streamlined because I think the time constraint is the biggest barrier. We don't do well on the hepatology side either. This global survey reviewed what do we do in hepatology practice when we diagnose patients with MASLD. Do we take care of their diabetes, hypertension? Do we refer appropriately or optimize? We don't do very well. We don't screen for depression, anxiety, sleep apnea, kidney disease, gout, which are all conditions that can be associated with this disease. So we need to develop and implement multidisciplinary MASLD care pathways, which are frameworks to support decision-making, risk stratification, and treatment and care, which will aim to identify patients at risk for fibrosis, minimize unnecessary specialty referrals to reduce healthcare costs and resource utilization, to link patients with the services they need at the right time, and to guide clinical decisions about the care they require. So these models don't really exist. There are very preliminary, rudimentary models that are mostly in Europe actually started, so there's definitely much room for improvement there. And I think as we develop and implement these models, I think we need to keep in mind not only the patient care, but also their reported outcomes, their experiences, the pathways themselves, how do they work compared to the standard of care pathways, what are the parameters, and what does this do to the healthcare system? What is the accessibility to the disciplines involved, and how is the access, the cost effectiveness? So this is a framework that needs to be kept in mind as we develop these models for highest efficiency and impact. So nowadays, based on the most recent guidelines from AASLD, this is what is recommended in terms of stepwise approach to clinical suspicion for MASLD. This was published before the name was changed. So this again starts from primary care or non-GI or hepatology care, and we first exclude, the goal is to exclude advanced fibrosis. So who are the patients who we need to send or not? And the first measure is the use of FIB4, as we mentioned. The cutoff to be remembered is 1.3. That's the lower cutoff we discussed earlier. If it's lower than 1.3, We don't forget about it. We reassess periodically. For those who have prediabetes or diabetes, we'll need to remember to recheck FIB4 in 1 to 2 years if these metabolic risk factors persist. If they don't have diabetes or 2 or more metabolic risk factors, reassess in 2 to 3 years. If they do have a FIB4 of more than 1.3, another line of non-invasive testing needs to be implemented. Some practices can refer to hepatology, but I think this will oversaturate our clinics because there are a lot of patients who would meet this criteria. So ideally, if possible, and if easy access, these should be done prior to referral, because if either their ELF score or their FibroScan are lower than these cutoffs mentioned here, 8 for FibroScan, 8 kilopascals, or 7 for ELF, they go back to the same reassessment of their risk in 1, 2, or 3 years. And if they're higher than this, they would get to GI and hepatology. And then we will take over in terms of, do we need to do further restratification? Do we need MRE, biopsy? Do we enroll them in clinical trials, and so on? What do we use at Mayo Clinic? We have this, we call the Ask Mayo Expert Care pathway, which essentially follows the same approach. FIB4 include lifestyle modifications if it's less than 1.3. If it's more than 1.3, we encourage our colleagues in non-hepatology to use either FibroScan or MRE. We have both there. I think you do have MRE here. The cutoff we use for exclusion is 3.6. This corresponds to stage 2 fibrosis. So these would be patients with low risk. We will consider repeating the liver stiffness measurement in 2 years if they follow in the same intermediate high risk based on FIB4. If the cutoffs are more than 8 and 3.6 respectively, they are referred to the Mayo Clinic. So this concludes the risk stratification. Once they're diagnosed and risk stratified, what do we do? So we'll review a bit about the management in the last few minutes. And I'll start by saying that weight loss, as of today, remains the first-line therapy. And how is this done? Dietary habits, this is a whole discussion for another talk, but in a few key points is that the bottom line is that Mediterranean diet is the one that's been most likely associated with an improvement in hepatic steatosis, but we also need to talk about portion size, when they eat, avoiding snacking, and leaving as much time between meals as possible. Carbohydrates, ultra-processed foods, restricted as much as we can. Fructose is everywhere. Carbohydrates are everywhere in our diets in the United States, especially in the Midwest. So I typically send my patients to a dietitian for another 40-minute discussion that needs to be importantly tailored to their dietary habits, preferences, and cultural habits, because we can say Mediterranean diet, but it's going to be very hard to apply from somebody who's used to eating a lot of rice and beans, for example, in the Hispanic community. So how can we tailor those habits to something that's a bit more impactful to their liver disease? A combined diet and exercise program leads to greater long-term weight loss than individually. There's insufficient evidence for specific activities and durations and intensity for MASLD specifically. A lot more work to be done there, but we follow the usual recommendation from cardiovascular risk of 150 minutes per week. One good thing is that patients would be encouraged, after we say all the no's, we say yes for black coffee. Coffee is actually has been associated with reduced fibrosis progression. Black and not sweetened, that's the caveat there. Anything above 3 cups or higher has been associated with a beneficial effect. Of course, consideration in those with AFib and other contraindications. Very important question we get almost on a daily basis in clinic with this disease. Can I use some alcohol? Can I use a drink a day? Can I drink on my birthday? What's the minimum safe amount of alcohol? And the answer is I don't know. It's very hard to study. There is no proven safe amount. I say minimize to discontinuation for those who have steatosis without fibrosis. Those with advanced fibrosis, I would recommend strongly complete abstinence. And simply, we do not know what this amount is. This is the weight loss pyramid that we keep in mind when we recommend how much weight should I lose, because that's the other question. We need to lose weight, but do we all need to get to a BMI of 22? maybe not, but what's that minimum amount that we need to lose to start moving the needle? So for steatosis, weight loss as low as 3% starts leading to improvement. And then we go high as the target is higher. So for those who have fibrosis, a minimum of 10% is the first goal. So it's not the goal, but the first goal in the stepwise approach. The problem with just lifestyle changes to achieve these responses is that they're very, they're suboptimal. So in studies that have looked at how often does this happen, less than 10% of patients in 1 year were able to lose more than 10% of weight. Luckily, the toolbox has expanded. I feel like Twitter has a new tweet about a new medication every few months now, and it's really good to know that we have these opportunities. It always starts, though, with this foundational approach of lifestyle changes with nutrition and physical activity, no matter how many tools on top of that we have and we apply. Knowing that we shouldn't really expect more than 5 to 10% weight loss from these changes alone, but also knowing that without these, it's going to be much harder for any of the above ones to be successful. So this is the bar we set. Try to change your lifestyle, about 10%, reasonable to target. The medications that are listed here can lead to up to 20%, now 24% with the most recent ones like tirzepatide. Semaglutide also is very successful in this as well. Again, knowing what do we shoot for, how much do we expect from these. Then we have endoscopic bariatric approaches who are now almost comparable to the most powerful weight loss medications, about 20% weight loss. And then bariatric surgery with bypass or gastroplasty with about 20 to 35% relative total body weight loss. So the paradigm of management of MASLD includes more than just liver-directed issues or weight-related issues. We talked a little bit about weight management, but we also have to consider their cardiovascular risk. Back to that reminder that they most commonly die of cardiovascular disease. So important to consider management of their metabolic syndrome. So with diabetes who are who have concurrent MASLD. The most impactful ones that have been studied and are currently actually in late phase trial are GLP-1 receptor agonists. This is currently a phase 3 trial now with semaglutide looking at MASH resolution and fibrosis improvement. Pioglitazone has been also shown to improve steatosis and steatohepatitis. So if we have a choice of insulin or metformin or anything, or these, consider these medications because of this added benefit in MASLD. Hypertension, the agents that are also proven to have an impact in liver disease are ACE inhibitors and angiotensin receptor blockers. For those who have dyslipidemia, any agents are safe. Important to know that if their aminotransferases are not normal, it's still safe to use statins if they have an indication based on their lipid panel. And also screening and treating obstructive sleep apnea is very important. The second cause of death in this population is malignancy, non-hepatic malignancy. There are no data on what medications can we use to prevent this risk, but for liver cancer specifically, there have been associations with use of metformin or simvastatin in preventing the risk of hepatocellular carcinoma. In liver-directed therapies, currently none are FDA approved for this indication, but there are several in late-stage clinical trials, which I'll touch on at the end of this talk. From the metabolic drugs with impact on MASLD, this is from the AASLD practice guidance that was just released a few months ago. It is important to know on this choice of medications for diabetes and weight, the ones that have a benefit in liver, but also cardiovascular risk reduction and stroke prevention, which are the ones highlighted here in red. So thinking of the patient as metabolic syndrome and liver being part of that would be the goal. So I will end with the liver-directed therapies in the last minutes of this talk. Remember the spectrum of disease that we touched on before, and I mentioned that the current trial focused on this population of advanced disease. We have had several years of unsuccessful trials for MASH because there's a very, very high bar in what a endpoint is considered successful by the FDA. And these are histologic at this stage in time. The two endpoints are resolution of steatohepatitis, which means that we cannot see a single ballooning cell in the tissue and the liver fibrosis hasn't worsened, or fibrosis has improved by one stage and steatohepatitis hasn't worsened, or both. So this is a really, really high bar. There are several limitations with histology, which I won't really delve with, but I wanted to mention why we've had so much trouble getting a drug approved for this disease. So how does this pipeline look currently? There are several phase 3 trials, which is a pretty good improvement compared to where we were a few years ago. And I've listed some of these just so you know what could be expected and when do we expect these results. The earliest that we are watching really closely is resmetirom. This is a thyroid receptor beta agonist, which is targeted to essentially treat the liver hypothyroidism that may contribute to this disease. And there are several that we wait until up to 2028. So I will conclude with the summary key points. Screen for steatotic liver disease in those with at least one component of metabolic syndrome, especially in those with type 2 diabetes. The next step now that we have to consider is this alcohol use and the opportunity to stratify these patients in MASL versus MET-ALD. Remember that cutoff of 2 to 3 drinks per day for women, 3 to 4 drinks per day per men on an average, or the weekly average if people tend to be more weekend alcohol users. The importance of this currently is more for kind of setting the stage. There is work on changing the ICD coding for the next stage of updates, and this is very likely to show as a separate entity, so important to know to categorize them correctly. We still need to learn more about the natural history of this disease. It is hypothesized that patients who have both components are more likely to progress, which would make sense, but we need more data to see if that's truly happening. The risk stratification is important. It's not presence of steatosis only, but it's do they have fibrosis or not? And for that, we use the FIB4 followed by elastography, or ELF if you have it here at WashU. And then referral to the hepatology clinic or a MASL clinic if stage 2 or higher fibrosis is present. Remembering that weight loss measure include that foundation of lifestyle changes, but the addition stepwise approach of pharmacotherapy, especially choosing those medications that have an impact on metabolism and ideally on cardiovascular outcomes, followed by bariatric endoscopy or surgery. MASL management includes good control of diabetes, dyslipidemia, hypertension, and sleep apnea, given their high risk of cardiovascular disease. Multidisciplinary care pathways are needed. Again, I think we're going to see more work on that, and they should be tailored to the current institutional availabilities. And lastly, we'll have liver-directed therapies on the horizon, somewhere maybe starting with 2024, 2025. And with this, I thank you, and I'll be happy to take questions.
Alina, thank you. That was really wonderful. A great overview and some exciting new developments for the field. So, questions from the audience for Dr. Vivian.
So, great talk. My question goes for sort of the newer data showing combination of, MRE, FibroScan with FIB4, sort of the fast and mass sources. So, do you think that's something that is ready for prime time? Should we start using that, or should we hold off? What are your reservations about this one?
Yes.
Just repeat the question.
Sure. So the question was related to something I didn't really delve too much into this talk, which is a fibrosis estimation using elastography plus blood biomarkers. These are used mostly in clinical trials currently. Their benefit is, so some examples include FAST, which is a combination of AST, steatosis by CAP on FibroScan, and liver stiffness measurement on FibroScan. This can be calculated by the FibroScan machine or even in a separate calculator. The other one is, there are two actually MRE-based that combine AST or FIB-4 score. They were developed for the clinical trial space to increase their positive predictive value of those who have advanced fibrosis, with the goal of minimizing the need of liver biopsies, which are still needed in clinical trials, so saving cost and saving risks for patients. We can use them in clinical practice. They are mentioned in the guidelines. I think for the sake of simplicity, I think right now we're starting really at the point of awareness in non-hepatology space. Remember they can have this disease, and remember that there are things we can do to risk stratify. And what are the easiest ones to do? Our blood-based biomarkers, followed by something else like elastography. We may go to a stage where we need to really fine-tune them, FAST, MEFID, MAST. I think at this point may add a bit more confusion, because there's so many, even for us in the clinical trial space, we don't know which one is the better one, what should we do, and so on. I think for identification of stage 2 or higher, which is the main goal of this, the non-combined approaches are sufficient. There are others I didn't mention as well, many other elastography technologies coming, some that may be laptop-based, so laptop to a ultrasound-like probe that also can be portable and used at bedside. Several things. I think if we have this talk again in 5 years, it'll look much different than it is now. That's a question.
Great talk. I learned so much. I want to ask your opinion, your clinical experience with some of the fibrosis reversal that you may see based on elastography. Because when you think about fibrosis, you think about matrix deposition, collagen deposition, and I'm just curious, I'm not a liver specialist, how much of that is actually reversible, and what stage when you feel is not reversible?
So the question relates to reversibility of fibrosis and how we measure that, I think, if I were to summarize. So the disease is reversible theoretically at all stages, but once we get to cirrhosis, it is a little bit harder. I think if we were to call a non-reversible stage, it would be that. I have seen patients with stage 3 fibrosis reverse with significant weight loss. So it's one of the things that we need to remember when we counsel the patients in clinical practice, because for us, it's of course it reverses, but for patients, it's such a big surprise, and their eyes light up like, oh, it can get better, unlike chronic kidney disease or after a stroke when things maybe are just kind of done. So it's a really, really important point. I'm glad you asked me this question. Steatosis is the easiest to reverse, as we said, followed by inflammation, but fibrosis can as well. It just takes longer. How do we measure that in clinical practice? Elastography methods are good. MRE is the best because it provides that granular performance of, is it stage 2, is it stage 3? FibroScan is more of a range, but that can also show some improvement in liver stiffness measurement. And we have looked at the next logical question, okay, so if the disease reverses or is stable versus if the disease progresses, the fibrosis, does that impact the patient's outcome? Does it make a difference? And in a large cohort of patients who had MRE, almost 800, we showed that in those who did progress when serial MREs obtained a few years apart, they were more likely to have liver-related outcomes and death than those who had stability or regression of the disease. So it is an important parameter to counsel on, measure, and target for therapy, either weight loss or liver-directed therapies, because it does impact the outcome of the patient. There's a question.
Thank you. Great talk. When you hear this topic, it's so hard not to just think about, you could be in a cardiology grand rounds hearing a talk on heart failure and preserved ejection fraction. Same patient, same risk factors,
Absolutely.
everything. So just curious, you mentioned in one slide briefly about maybe the role of SGLT2 inhibitors. Could you elaborate maybe, is there any more evidence that might have any direct benefit on the liver, or is it just maybe improving the overall metabolic situation in those patients?
Thank you for the question. So this relates to the role of SGLT2 inhibitors in this disease. And you're correct that when we talk about this patient, it's not just liver. That's why the point I was trying to make this whole time is we're all in this together. And we all kind of target our own organ, but it's one patient, one system, one body. So how can we make use of a medication for one organ that impacts all the others? Specifically for the SGLT2 inhibitor, the data is not as strong as for GLP-1s, for example, but there are studies that show that there is improvement in steatosis and inflammation. The biggest outcome we all want is fibrosis reversal. There's no evidence yet, but there are ongoing studies for that. But it does seem to impact steatosis, so I think there's potential there.
Very nice. Maybe this question is something for black coffee and discussion, but how's the society doing with the pathologists and the lab stuff? There's nothing that gets people's attention better than a big red exclamation mark next to an abnormal laboratory finding. And with regard to ALT, we've always included those healthy people with fatty liver or MASLs in that group so that we have this very high ALT cutoff in general across the country. And I know these societies have been trying to get the pathologists and the clinical lab people to lower that. Is that going to happen anytime soon?
That's such a good question. The question was, do we upgrade or adjust the normal ranges for ALT, knowing that a lot of people will have mast cell? Then obviously that will increase that mean, right? I think it's a reasonable point. We use that in hepatitis B guidance, for example. In hepatitis B management, we use a cutoff of 19 and 30 for ALT. Not so much in this disease, but, and I, to be honest, I haven't heard of any plans to do that, but I think that would need to be done with such a high prevalence of this disease. So that's a really good point you bring. I didn't see the connection for black coffee, though. Was there a question about that, too?
No.
Oh, just to mention that we can drink it.
He's drinking it.
Okay.
All right. Well, if there's no more questions, let's thank Dr. Alina again. Wonderful. Great job.